We're going to give it a brief minute, everybody, just to let people filter in from the waiting room, and we'll get started in just a minute. Okay, I think we're good. Let's people will trickle in, but I'll just be doing a brief introduction. Well, hello everybody. Welcome to our webinar on retrograde cricopharyngeal dysfunction. We're really delighted to have you here today. We have a wonderful panel of incredibly fantastic colleagues who treat this disorder and are here to help us understand more about it. For those of you who are joining us, the audience tonight is anybody from the patient, the layperson, the non-medical professional, probably to some of our colleagues who are watching from across the country. So we're really happy to have all of you. Please remember to put questions in the chat or the Q&A, and we will monitor them. And we will hopefully have time. We'll try to leave about 15 minutes at the end for questions from the audience. So let me introduce the panel briefly and we'll get started. So from the Chicago area, the Bastian Voice Institute, Chicago, Illinois, is Dr. Robert Bastian. From Jefferson University, Dr. Joseph Spiegel in Philadelphia. From New York City, Columbia University, Dr. Michael Pitman. And from the University of Southern California in LA is Dr. Karla Odell. I'm Tom Carroll from Boston at Harvard University, and I'll be moderating the panel tonight. So the objectives of our hour together tonight is to explain RCPD, which is retrograde cricopharyngeal dysfunction, to patients, their families, and their clinicians, characterize the presentation, workup, and treatment of RCPD, and also empower patients to speak to their doctor about this lesser known disorder and seek effective treatment for their symptoms. So we will start off with a brief review of anatomy of the laryngopharynx, which is basically your throat, and how RCPD affects people, which we call the pathophysiology. So Dr. Bastian, if you'll take it away, you can share your slides.
Okay, here we go. Okay, I guess I need to enlarge this. Somehow it got, there we go. Thank you very much for the invitation to participate. What I want to just mention right off the bat is that we have made a very large resource page on Laryngopedia. So anybody who wants to read or learn additionally, you can go to Laryngopedia and just type RCPD into the search window. Well, what is RCPD? It stands for retrograde, meaning reverse direction, cricopharyngeus, that's the muscle in the upper esophageal sphincter, dysfunction. It's a disorder of the upper esophageal sphincter found right here in the middle to low part of the neck, just below the Adam's apple or the Eve's apple. Well, what is a sphincter? It is a circular muscle. It's a ring muscle. My bicep is a longitudinal, is a straight muscle, but it's a ring muscle that regulates the entrance or exit of something through a passage. And so here are a couple of very common examples. The iris of the eye is a sphincter, and it's an active sphincter that can either open or clamp shut. And what is it controlling the passage of? Light into the back of the eye. So that's a sphincter. The mouth, here's a little child saying, no, I won't eat my carrots. So there's a sphincter that can close and regulate the passage of carrots into the mouth. Well, in the GI tract, there's a whole series of sphincters. The lips, technically, there's a circular muscle around the lips that allows to purse or pinch. There's the upper esophageal sphincter, which is the main one we're talking about. It's right here in the upper part of the esophagus. It divides basically the throat from the esophagus. The lower esophageal sphincter, pyloric sphincter, ileocecal valve, not quite a sphincter, but sort of, and the anus. So all of those sphincters in the GI tract are mostly being used in an antegrade direction. It's true we can spit through this way, but mostly we're taking things in through this sphincter. We can burp or vomit, but mostly the upper esophageal sphincter is taking things in an antegrade, which means downward direction. So just to look at the sphincter in a few shots here, we're looking right in this is the airway right here, this is the trachea right here, and this is the foodway or the esophagus. So the sphincter sits right here at the tip of my finger. And what we're doing in these views is we're taking this and we're looking online this way with the airway being right here between the vocal cords. So go through there and you're in the trachea and on your way to the lungs. Go through what I call the swallowing crescent up here, and you're on your way to the esophagus, stomach, and GI tract. So here we have a view just below. You see food that's wanting to make its way through that sphincter. It's above the sphincter still. And here you see the actual sphincter, and you see the little opening here. And if this sphincter remains contracted in that way, the opening is quite small, like the iris of the eye that you saw. And here's another view showing that sphincter. And this is the muscle that we inject when we're dealing with RCPD. This is turned upside down. So that's the sphincter muscle, the upper esophageal sphincter. And when we swallow, here's an X-ray radiograph showing barium going into the foodway. Here's the airway up here, the foodway. The sphincter is right here where the two green arrows are, but it's relaxed. And so you do not see any indentation. You see no narrowing in the passage of the barium. On the other hand, here you see a sphincter that is the upper esophageal sphincter or cricopharyngeus muscle that is not letting go. And so the person is having to swallow down through this little tiny, I call it Mississippi River, Shoal Creek, and Mississippi River. So you can see that there's an impediment, especially to solid foods, through that passage. Well, these two sphincters, the upper esophageal sphincter and the lower, are mostly, again, for antegrade, which means downward passage, but they must work also in the retrograde direction for burping and for vomiting. So especially this sphincter right here, the one that we're talking about tonight, the upper esophageal sphincter or the cricopharyngeus muscle, they're not exactly synonymous terms, but close. So retrograde, R is for retrograde. So that means reverse direction. Cricopharyngeus dysfunction means the sphincter won't let go fully in the reverse direction, and therefore the person can't burp. And many people with RCPD also can't vomit, or they can vomit only with the most heroic effort. It's what I call a Incredible Hulk kind of vomit, because the sphincter just won't let go in that reverse direction in this group of people. Well, here is a depiction again of the cricopharyngeus muscle. That's the sphincter that that is troubling us when we can't burp or vomit. And so imagine when you're trying to put air upwards through here, what does it do? It doesn't bother the upper part here. It bothers what's below. It interferes with the esophagus. The esophagus begins to stretch and dilate. I've drawn this little red thing to show you what might be the diameter of a normal esophagus without blowing any air in there. It's kind of mostly collapsed. It may open briefly just at the moment of swallowing, but it's going to sit in a semi-collapsed or mostly collapsed shape, especially in young people, not always in older people. Well, here is the actual esophagus of a young person with cricopharyngeus dysfunction. You see the tracheal indentation here. You see the spine is up here, though neither of those is compressible. And so you can almost see that the walls of the esophagus are stretching laterally because it's all the distance they have. That's the only direction they can go. And so this is a very common finding in people with RCPD. It's a routine finding that without blowing any air, they've already got their own air in there, keeping the esophagus quite open. And they also then back up air from the stomach. They back it up into the small intestine, the large intestine, and we get misery. So here is the same person. Notice the little mole here and the little mole there. It's the very same person. There is absolutely no weight loss, change of weight between these two pictures. This is the person in the morning. Here's the person in the afternoon or evening. So the air builds up and builds up, and to see it radiographically, and these are kind of common pictures. I don't get these pictures, but patients, I don't order these pictures, but patients bring them to me. And here you see someone with a massive amount of air in the stomach. The normal air bubble would be above about the line that I'm drawing with my cursor. So you see this massive backup of air. This is the transverse colon filled with air and the descending colon. So the symptoms arise from these mechanical stretches. We get gurgling, bloating, distension. We get hiccups. You know, somebody's diaphragm is being lifted by all of this excess air. We get damage to the lower esophageal sphincter because, of course, all that back pressure and constant pushing, trying to get air out against this block causes damage to the lower esophageal sphincter. So there's a great amount of acid reflux in this group. And then here you see the very pictorial depiction of the flatulence that is extraordinary. It's extreme. I had one person say to me, I get up in the morning, well, many are deflating through the night. So the bed partner says, but this one person said, I get up in the morning, I sit on the toilet and I can pass gas continuously for 1 minute, just passage of air without stopping for 1 solid minute. So imagine, is that good for the stomach? No. Is that good for the esophagus? No. Is it good for the colon? And so therein lies the whole constellation of symptoms. Here you see the lifted diaphragm with this huge air bubble, and notice all the air in the colon. And this is a man who had an absolute crisis. You see, he's got air in his GI tract here, massive stomach bubble. This doesn't need to happen to anybody. This man did absolutely all the wrong things in a well-intentioned way and totally throw himself into this crisis. And you see all the air here, and you see that he's actually kinked off, so he can't pass gas and he can't do anything. So he had to go to an emergency room. And so you do run into the occasional person who has this kind of an abdominal crisis. So the syndromic diagnosis is people say, I can't burp. They often say it started in high school, it started when I was 9, but what they mean is they became aware of it at 9 or in high school or first year of college. When you ask them, could you burp before you became aware of it? They pretty much all say no. Some have rare burps, some have spontaneous little burps here and there that are non-relieving and they can't harness them. And you exclude infancy because 2 out of 3 did burp in infancy. So we're not exactly sure when the actual syndrome begins, but it's prior to the person's memory. Gurgling, and you can imagine why. There's saliva bubbles in the esophagus and there's this turning back and forth. They can feel it coming up and down, and so it gurgles. And in some cases, it's mostly internal. Some cases you can hear it across a large room. Very embarrassing. Bloating, and I've come to use the term bloating to mean any kind of fullness, which could be abdominal, chest, or even low neck. So there are 3 levels of discomfort, and abdomen is the most universal. But when people have the chest discomfort, some of them say that's more uncomfortable than the abdomen. The abdomen can stretch, the chest can't stretch. And so people describe quite a bit of discomfort in the chest and trouble breathing with that raised diaphragm that you saw. And then the extreme flatulence. And now and again, there are people who say, yes, we use pregnancy as an analogy. Yes, I'm 6 months pregnant, male and female by the end of the day. I don't know that I have that much flatulence, but the bed partner says yes, all night long. So the major symptoms: can't burp, gurgling, bloating. This is from the original description, and it's a durable major syndrome. I can't burp, and it's been basically lifelong. A few are acquired, but not very many. Gurgling, and it's kind of chest and throat gurgling, bloating and distension, and flatulence. Other symptoms: nausea, hiccups, hypersalivation, shortness of breath, and constipation even is a significant issue for some. This gives rise to my little adage, which is if you fit the syndrome of RCPD, all of your GI symptoms are due to RCPD until proven otherwise. Everything from top to bottom, all the way from can't burp to constipation. So in summary, RCPD is a remarkable disorder. It's absolute misery, but it is fixable. And the two ways to fix it are Botox, and you can do that either endoscopically or via EMG in the office, and myotomy. Those are the only two ways that I know of so far to fix this. So there's a quick summary.
Excellent. Thank you, Dr. Bastian. So we'll jump right into some questions for the panel. Our first question goes to Dr. Joseph Spiegel. Is there a typical workup for a new patient with RCPD who presents to your clinic, and has that changed over time as you become more comfortable and familiar with the disorder?
Well, thank you very much. And I'm also going to start by thanking the audience that brought this syndrome to us, and one of the things that makes this so unique. Really not very much of a workup beyond the examination in the office. I think we came pretty quickly to the conclusion that when patients present with those four major symptoms that Dr. Bastian just noted, plus the negative symptom of not having problems swallowing food or liquids, that when you add that negative symptom to these four, we feel pretty confident about the diagnosis, and we move on to treatment. And we don't ask patients to go through more workup than the examination in the office that we're doing to endoscopically examine their throat and do a typical full head and neck examination. As you know, many patients, especially young women, have gone through a workup, normally with gastroenterologists, because of the complaints of bloating that can also mimic other diseases. So some of our patients have gone on other workup, but what we found pretty early is that almost all the other workup is negative, whether it's a video swallow, a barium swallow, GI endoscopy, some of the other studies that are done through gastroenterologists. So we've pretty much gone to treatment, and the response to treatment is our next metric. I will say that we have taken most of our patients that have not had other workup to the operating room to do the initial injection. At that time, we also do esophagoscopy and biopsy, and we do have some interesting findings from those biopsies that may lead to more information down the line as terms of the ultimate cause of this, or the cause of failures. But that's just sort of part of the treatment algorithm at this point.
Okay, great. We may get to a little more of that later. Dr. Odell, any other thoughts on the typical workup or how your experience has changed over time?
Yeah, so for me, fairly similar. I mean, I think the history is the most important thing. So really what the patients tell me is what I go my diagnosis on. I do an in-office laryngoscopy. And when I had my first few patients, when this was a relatively new condition to me about 3 years ago, I actually did do pharyngeal manometry and esophageal manometry, as well as modified barium swallow or swallow studies, to sort of get a better sense of what's happening in this situation. I stopped doing the manometry because it's fairly invasive. And again, I found that on modified barium swallow or on the swallow studies, everyone has been very normal, and the cricopharyngeus muscle appears normal during the swallow. So I really don't think that those diagnostics are important for the diagnosis.
Excellent. And next in line to comment, if you'd like to, Dr. Pitman, any other thoughts on things you do in your workup or anything that we haven't talked about yet?
Yeah, so I've had the same history as Joe and Karla and Bob, where I was doing stuff we don't do it anymore. If you've got the four cardinal symptoms, you've got it. The one caveat is some of the patients who are much older, because their esophagus is not working well, and the lower esophageal sphincter is not working so well, they may have a lot of reflux or even some regurgitation. In those patients, I'm a little bit worried that when we Botox them and the upper esophageal sphincter is not going to work for 2 or 3 months, that they'll have, tons of reflux and regurgitation. And it's really hard to control. And we want to know that beforehand. So occasionally in those patients, we might do a manometry just to see what the lower esophageal sphincter is doing, or a barium swallow to see if there's real gross refluxate and an ineffective esophagus, to give us a little bit better idea of what that post-op situation is going to feel like to those older patients. So anyone who's, the typical between 20 and 40 years old, we don't do anything. If you're older and you don't really have complaints, again, just history. But if you've got that history of really bad GERD or regurgitation, bad reflux, and you're older, I'll do a little bit more for those patients.
Yeah, I think it's an interesting point, and I'll get Dr. Bastian, I will get you in one sec. I actually in the beginning started doing reflux workups on everybody before I started doing the injections. And I realized most of these patients, even if they have some reflux, the Botox will officially wear off at some point. So patients need to know if they do get really bad reflux, unlike the ability to learn to burp, the reflux typically will get better over time, and the ability to burp will often stay. So Dr. Bastian, any further comments on the workup?
I was just going to say the very first patient in the original series was a man who'd had endless testing. And so the original purpose of the Botox injection was to serve as much as anything as a test, because people had had every test known to man. They'd had manometry, they'd had multiple scopes, they'd had gluten workup, testing for SIBO, all kinds of testing. And so I began doing this series just as a diagnostic test. And we are now at 1,210 people. And I have not yet ordered a single diagnostic test in any of them, because I kind of figured this population is kind of beaten up already by tests. Many of them are skeptical. They're even jaded, occasionally even almost a bit hostile because of all of the tests they've done and the people they've seen with absolutely nothing to show for it. So my personal view is, if you fulfill the syndrome, you go straight to the procedure, because it's a test. It's the best test. You can fashion myotomy to reveal the diagnosis, but you already know the diagnosis. If you just do plain old manometry in people and the doctor doesn't know about this diagnosis, it's never diagnosed.
And I'll just bring up for some of the people listening, the concept of injecting Botox into the upper esophageal sphincter is not new with this condition. This is something we've been doing for quite some time for other problems with swallowing. So that's why we've adapted to this so quickly. We know how to do this, and we know it's a safe procedure to do. And we've dealt with the minor side effects of doing this, mostly minor, that patients have gone through, so that adapting it to this condition has not been that difficult. This is not a new treatment. It's a new condition that we've adapted a known treatment for. So I think that's why we've been able to do this. We understood that we could do Botox injections, perhaps reverse the initial problem immediately, and then deal with any of the minor issues that come as a secondary problem.
I'm going to switch up our order just because I think this will follow nicely. So Dr. O'Dell, can I ask you a question? What are the negative risks or any side effects that you tell patients about potentially from doing a botulinum toxin injection via various routes, of administration? And, if we want to combine this with the question of sort of how do you decide where to do it, you can do that if you'd like to, but Dr. Pitman may have some stuff to add on that next.
Yeah, I think it's important to explain that Botox is a muscle relaxant, and that's how it works in cosmetics, and that's how it works in this fashion. And so it's going to relax the muscle that you inject it to. And so, Dr. Bastian very nicely showed on his slides the anatomy of the cricopharyngeus muscle. And sitting next to the cricopharyngeus muscle is a muscle called the inferior constrictor. And that muscle is what helps propagate things forward when you're swallowing. And so I think one of the side effects of Botox is that the Botox doesn't fully or leaks out around around the cricopharyngeus muscle and instead gets into neighboring muscles. And so if it gets into the inferior constrictor, then I counsel patients that they can have some difficulty with swallowing. There's also the muscles that open and close, that open the vocal cords, called the posterior cricoarytenoid muscles. And so if that were to leak out in that direction, you could, I guess, get shortness of breath from that, because then the vocal cords wouldn't open all the way. I would think that that's actually a little difficult to do, but I have had one person who had a little bit of extra Botox in the inferior constrictor and had some transient difficulty swallowing in the initial period for the Botox. And then, as kind of was mentioned by Dr. Pitman, your protection, if you're having acid from coming up into the throat, is that cricopharyngeus muscle. So weakening it can result in reflux that comes up into the pharynx, which can cause throat pain and other symptoms. And I see that. Usually the effect of Botox is going to be in that initial period. It tends to have the strongest effect, and that tends to dissipate as the Botox wears off.
Dr. Pitman, what do you do to manage some of those side effects? What are some options patients will have if they do get bad reflux or have dysphagia?
Right.
Swallowing?
So I think actually the gross majority have some dysphagia if you're going to, ask them closely. And so one of the biggest things is just to tell the patients up front what to expect, that you're probably going to get dysphagia between week 1 and week 3, and you're allowed to eat whatever you want. Typically, you'll defer to softer foods, maybe take a small bite, wash it down with some liquid. It might take you a little bit longer to eat. And I think actually letting them know that ahead of time is one of the best things. And same thing with people that I'm worried are going to have a little bit more reflux or regurgitation. Like you said, that is only going to last 3 months. Once the Botox wears off, that regurgitation in the throat will go away. And so pretty much for those patients, it's small meals. If you might want to raise your head of bed at night, not to eat 2 or 3 hours before you go to sleep, so that gravity kind of keeps things down. Don't eat right before you go to the gym. I have them either use Gaviscon Advance or Reflux Gourmet, which, as we know, has sort of a seaweed barrier that puts a barrier on their stomach and helps decrease the reflux a bit. And there's no perfect seal or cap that we can use to inhibit that reflux. So you can only make it just a little bit better by management. And so really the biggest thing is just to emotionally coach them through that time period and let them know that it's going to go away. The same thing I have had if you do in-office injections, you can get the opening muscle of the vocal folds a little bit weakened, right? Because again, in the office, the cricopharyngeus is right up against that muscle. In the OR, we pull that away. And so that's not going to be a side effect in an OR injection. That's one of the benefits of an OR injection versus an office injection. But I've had 2 patients, because I inject unilaterally, who were a little bit hoarse for 3 or 4 weeks. One was a teacher, and he just had to use a little bit of microphone, and then it wore off. So, letting people know, I think, is the most important thing. And then these are some of the little tricks to, get over that hump and make it a little bit easier while you're dealing with it.
And we'll talk about the routes of administration in just a second, more detail. But Dr. Bastian or Dr. Spiegel, maybe Dr. Bastian, you can start since you're next on my list. Are any other risks or things you've learned over the 1,000+ patients that you've done, and anything that's come up that was unexpected or you see regularly and warn patients about, but say this is kind of part of the deal?
Just echoing Dr. Pitman, if you do EMG, there is a little greater incidence of voice change and occasionally a little bit of breathing symptoms, but nobody's gotten into any trouble. We've had about 25 of the 1,200 people who described laryngospasm, most of them very minor and non-frightening, and about 3 or 4 of them where it was quite frightening. One of them was EMG, and I think I just kind of irritated the larynx. And so I mentioned it to everybody, laryngospasm. As for the operative complications, you can imagine there are people who are quite difficult anatomically. And so I think I've had a couple with a little roughened tooth. I haven't had any broken teeth or anything like that. Just a little simple filing and not even a trip to the dentist. Had one fellow who said he had micro like electric shocks for about 2 months, not a loose tooth, nothing wrong, but he just, and then let me think, I had one patient, she's my all-time hardest anatomical patient, retrognathism and very big teeth, who I created not by carelessness, but just by the effort of getting the view. There was an abrasion on the posterior pharyngeal wall. She had a little bit of pardon me, getting over a cold, a little bit of cellulitis and needed antibiotics. Aside from that, I think that's it. It's a very straightforward procedure, very low complication rate.
Yeah, Dr. Spiegel, any final thoughts on the
I could
negative
just say
side
we've
effects?
had literally zero operative complications in the more than 100 people we've taken to the operating room. We've had a couple of patients with breathing difficulty. We documented one with mild transient bilateral vocal cord weakness in abductors, but both patients were very high performing athletes where they were really only out of breath doing wind sprints for 3 weeks after the procedure. Actually, both reported that they were so much happier not being bloated that it was sort of a tough decision one way or the other about whether the breathing was bothering them that much because they were running better because they weren't bloated. So I don't consider it a big problem, and I haven't changed dosage or technique at all because of those minor things. Now I'll be very interested in what Dr. Pitman says. I'm not sure we have enough, but we really haven't noticed a difference in whether it's an office technique with an EMG versus an operative technique in terms of the appearance of these minor side effects.
Excellent. And Dr. Pitman, maybe you could describe for the audience the actual, like what to expect on the day of an injection, if it's in the office versus the OR, like just take us through a typical patient experience in your practice. I think you're muted.
Oh, certainly. After we talk about what's going to happen, starting day 5 or 7 when the Botox starts to kick in, which is actually pretty much the same whether you do it in the office or the operating room, we then talk about your different options. And I think it's fair for the patients to choose either the operating room or the office. I don't really necessarily think that one is necessarily better than the other. It's really what a patient's preference is. So in the operating room, usually if you're older, you have to get just cleared from your doctor for surgery. Anyone over 30 in our institution, it depends on your institution. Anyone under 30, we can just clear them ourselves. And then you show up to the operating room. You'll have general anesthesia. The surgery takes about 40 minutes altogether. So essentially putting you to sleep, doing the procedure and waking you up, and that's it. And then you need someone to take you home. Because the anesthesia is relatively short, there's not a lot of hangover. And by the next day, you're generally feeling fine and there's no restrictions and you can do whatever you want. The main risks that are different in the operating room versus the office are the tooth issue that Dr. Bastian talked about. You can get a little bite on your lip, and also just the hassle of having to schedule the operating room, going to the operating room. It usually takes a couple of months to get in the operating room because of the scheduling situation there and how many RCPD patients we're actually seeing. We probably do 4 or 5 a day in the operating room when we do that now. And so that's one option. And the results there, I think we get a good hit, and we've talked about it among this group. When you take some of the operating room, you're going to get a good hit from the Botox about 98, 99% of the time. Not everyone's going to be 90 to 100% better. There's a certain percentage that are maybe 50 to 80% better, and we can bump them up with another shot to that 90 to 100% better. In the office, you just come in. It takes just like an office visit, maybe 15 minutes in and out. And you just pass the needle through the neck. For people who don't understand what an EMG is, you are hooked up to this EMG. No discomfort in being hooked up to it. It's just pads that are taped to your neck. And on the tip of the needle is a little electrode that picks up the electricity of muscle. And when we put the needle into the muscle of the cricopharyngeus, it will pick up the electricity of that muscle, and we can see it and hear it on the EMG. And then we can have people swallow, and we'll see a pattern of the relaxation of the cricopharyngeus, and then it quiets, and then a crash of the EMG activity when the cricopharyngeus reconstricts after the swallow is over. When you see that pattern, you know that you're in the muscle. Okay, and that literally takes about less than a minute. Now, some of the injection techniques are a little bit different. I know Dr. Bastian gives you a numbing shot in the airway first and goes right through the airway to get to the muscle. You don't do that anymore, Bob?
I have 2 ways of doing it.
Okay.
Mostly I do laterally, mostly.
So that's how I do it. So I go laterally as well. and I inject in one side instead of both sides. So the one caveat is if you inject on both sides, there is a little bit more risk of weakening both of those opening muscles to the vocal folds. And like Dr. Bastian talked about, you can get some breathing difficulties for that. There hasn't been anyone who's had any real significant dangerous breathing difficulties, but because of that, I go unilateral. I use a little bit less Botox. Instead of using the 80 units that we pretty much all use in the operating room, I use 30 units, okay? And my hit rate with that is about 70%. And when you hit it, again, the results are exactly the same in the operating room. So the trade-off is that sort of 98% versus 70%. And I'll tell you, it's about 50-50, which patients really want to avoid the operating room and just come in 2 or 3 weeks and get the injection in the office. I've changed my technique a little bit. We're all scientists, and I guess Bob's changed his too, to try and improve it, make it better for the patient, for him, and I'm interested in what he's doing. And so what I do now is I actually make a line at the bottom of the cricoid, and I go in and sample the muscle, then I move up 8 millimeters, sample again, move down 8 millimeters from the midline and sample again, and see what's the best tracing. And if you get, and where the tracing is really strong, then I give you an injection. And with that, I think that we're getting probably in the 80s, mid 80s success rate, but we don't have as big a large number of patients with that technique now. But when I get good trace, so I'm also we're doing a prospective study in all of our patients where we have them answer questionnaires and look at all this stuff and dosing and stuff. And one of the things we're looking at is if I get a good tracing or a fair tracing, what's the result? When I get a good tracing, so far, almost all of those patients are having the exact same results they do in the office. I mean, sorry, in the operating room. So essentially for patients, it's really a balance, right? A little bit more of an annoyance getting the operating room, a little bit more of a delay, slight increase in maybe risks, and you have to have general anesthesia versus getting the office quite quickly, having a very fast procedure. You can even go back to work right afterwards, but having a little less success rate. But again, what's really important, it's when you do hit it though, the success rate is exactly the same between the two in the operating room or in the office. It's just that sometimes it is more of an art and you're maybe just not quite as accurate.
Dr. Bastian, do you want to give us a comment or two about how you're administering how you choose who gets to the office versus the OR, or what are your thoughts?
Yeah, I offer whichever people want, but I would just add a couple of things. It isn't a terribly comfortable procedure, and so it varies a lot. There are people who say that wasn't too bad, and there are other people who say, oh, there was a deep pressure and ache in my neck, and they don't like that. So, and our success rate is actually very close to the OR. It's just that you have that little bit higher rate of voice change, a little bit higher rate of breathing difficulty, and so that's the reason I tend to kind of lean people a bit to the OR is that so many people come from such a distance. The example that comes to mind, the one person I can remember that I just missed with the EMG was a fellow from Denver. So he had come all the way from Denver, and that was his choice. And, you know, we had met online and I explained the pros and cons, and he's the single EMG that I just totally missed. And so when people come a long distance, if someone's from Chicago or a two-hour radius, I'm a little bit more okay with doing the EMG, because if it doesn't work, it's not a plane trip and all of that to come back and redo it. So you can do the EMG trans cricothyroid membrane. It works very well, the same way you do the PCA injection for SD, but you just have to go beyond so you are having people sniff constantly and you get beyond that muscle, excuse me, and that's where you inject. Laterally, I tend to be sort of level with the bottom of the cricoid and maybe angle slightly upward, and that seems to be a pretty good hit for, but in the operating room, the way I describe it for people is I say, when we leave the pre-op area, I talk to them in the pre-op area, we taxi down the runway, we take off, we fly a few minutes, we land and taxi back to the terminal all in about 30 minutes. Yeah. So it's a very short procedure, and they're usually with us about 2 to 2.5 hours from when they arrive and sign in until they're leaving. I also say to them, now, the nurses wouldn't like hearing me say this, I'm not recommending this, but I'm just letting you know what people do. People finish in the OR, they go downtown to sightsee if they don't know Chicago, right from the day surgery center with someone else. They get right in the car and go to the airport to fly home. They get in the car and start driving back to Ohio, or they go straight out to breakfast. So again, I'd say I'm not recommending any of those things, but I tell people that to give them a sense of the magnitude of the procedure. You're not going to go back to a motel room and groan in pain. It's quite, you're kind of back to yourself pretty quickly, and you just have this sore throat. And I tell them the soreness is from the poke. It's not from any inflammation. It's not like a vaccine. There's no inflammatory response. And most people in recovery room, when you ask the 10-point scale, they'll say a 3. And I believe it's been at least 100 people since I wrote pain medicine. So they take Tylenol or sometimes Motrin or sometimes both, but I almost never write I'm happy to, if they need it, I'll be glad to write something stronger, but they just don't seem to need it.
I think the pain's a great point, Bob. Like, I just say Tylenol, Advil, that's it. And I think that really drives home what that procedure is about. Yeah. And most people don't even take that.
Yeah.
And I just wanted to add, I won't compare because I don't think we have enough patients to really say, although we've had very good response to the office-based injections, I generally do transtracheal technique through the airway. But I'll just say, I literally 100% of our patients that have had it in the office have said that they would have it again if they needed it again. They don't leave with a lot of soreness and go about their daily activities on the same day after the injection without any difficulty.
Yeah.
So once
I
they
get a
have
lot of the
injection, we're starting to see patients back for multiple injections because they feel it's a very comfortable experience to have it at a 6-month interval if they need it again.
Yeah, I get a lot of the, is it done already? and I was up all night worrying about that. Isn't the two things?
I just want to jump in. We just have a few minutes before I wanted to look at our Q&A questions, but just sort of to round things out, 'cause I know people often wonder, how often do they have to get another injection? And what's kind of the natural course for most of our patients who get this procedure? Is it one and done? And when do things start waking up? Does anybody teach them how to burp afterwards? Like, what are some of the expectations that we should have for our patients? Maybe I haven't heard from Dr. Odell in a while. Maybe you want to field something on this one?
Yeah, so, I think the hallmark of this condition is that the Botox wears off in 3 months, but the majority of patients seem to get a long-term benefit from a single injection. And a lot of what I've taught patients is related to what patients have told me that they found effective when they first started feeling the burps. So a lot of patients describe that, like, initially they have to do a little bit of a head turn to sort of release, like when they're first starting to feel the Botox come on. But yeah, I think that the natural course has been that people overall get really relief of symptoms. And that's why, from the beginning, I've really enjoyed taking care of patients with this condition, because this is something that they've suffered for a very long time. And as you guys have very nicely described, the procedures are relatively straightforward and easy, relatively not very uncomfortable, and seems to be curative. I would say there's a small percentage of patients that I've treated whom have had a partial improvement, where they kind of could do like the micro burps and could do a head turn, but didn't get the full benefit. And so I've taken them back at 6 or 8 months. And it's not like they lost that ability, it just never got to be easy, and redose Botox at a slightly higher dose. And that seemed to have an improvement. I've yet to have somebody whose the effect of Botox has worn off. I don't have 1,000 patients that I've taken care of, but in the 3.5 years that I've been treating this condition, I haven't had to retreat somebody.
Excellent. Any other thoughts from the panel on that?
We've had about, I think it's up to about 18% of our patients have had more than one injection and have come back. There's a group that have had a partial response, and there's a group that have had a transient response, where they've gotten better for a month or 6 weeks and then feel like the response has dissipated. So we've re-injected them, and we've re-injected the couple people that have had a great response, but then had it dissipate very quickly. But I've also been impressed now that we've been following people that have been a year from their initial injection. Many of them tell us they're not 100%, but they're 75 or 80% better, and they're almost never bloated. and they're very happy with their situation at that point. They might not be able to belch as on command as they were the first 3 months, but with the bloating gone, that's really, I think, the issue. That as long as they don't have that issue anymore, they don't necessarily come back for more treatment.
I could just say our original 51, the original description of this disorder, we've just looked at them again because all 51 are now more than 5 years out from treatment. And these aren't exact numbers, but it's something like 66% are still burping. And that was with 50 units. We used 50 units for our first 200. So something like 66% are still burping, except that assumes that the 11 we lost to follow-up are not burping. So if we said, well, some of those who we've lost to follow-up probably are burping, it's probably back to our about 4 out of 5 burp long-term. And so it's kind of an interesting number, approximately 80%. It seems to be once and done. The median age for the once and done is about 25. The median age for recurrence is 35, but there are 18-year-olds who recur. There are 60-year-olds who are once and done. So it's not but the trend is the older group is a little less likely to be, they're still overwhelmingly more likely than not, but they're not as likely to be once and done as the young crowd.
One of the questions that came in from the audience was, has anybody noticed any familial trends or genetic component with this syndrome? I know we were talking before the crowd joined us, but we've seen some parent-child pairs. Any thoughts from the panelists on that? Is there any familial tendency in this? And is that because it's a reflux-related tendency as well, or is it totally separate?
I mean, I think we can all agree that there is some familial penetrance. We don't have enough patients to say what percentage of that is, but we've all done parents and their kids. Sometimes we do them the same day. You know, I've had some parents who they want to do before their kid, other parents who made the kid the guinea pig. You know, so there is some. I don't actually think this is a reflux problem. I think this is a neurologic issue. You know, it's sort of interesting. When it was originally described, they actually pumped air into the esophagus and at super pressures that should definitely have opened the upper esophageal sphincter, and it didn't. So to me, that means there's something there with the distal esophageal sensation and that sort of reflex arc up to the cricopharyngeus that's abnormal. I don't think reflux is really an issue, especially because, you know, it's lifelong, right?
I would just say, you know, we have 5 pairs of identical twins now, both of whom couldn't burp. So I've treated 10 people, 5 sets of identical twins. We've got 3 generations. I have a family of 8 children, 4 can't burp and 4 can burp. So there's definitely some kind of a familiar thing. And I've been accused of being too imaginative for medicine. I'm not scientific enough, but I don't think it's neurological. And the reason is that, remember at the very beginning, I said, this is just a test to prove the diagnosis. And my thought was they would all need a myotomy, because I thought, well, who wants to be injected every 4 months for the rest of their lives when they're 18? And so I just did them as a diagnostic test. And I was surprised that so many of them were once and done. And so I had to think, well, what kind of a disorder could you have for 18 years or 30 years or 50 years, and you get 1 Botox injection and it's fixed? So it made me think the following. It made me think that there is a segment of human beings who, as infants or very young toddlers, experience that kind of cascade of sensations that should lead to a burp, and they do the wrong thing. They don't know they're doing the wrong thing, but they clamp or they do something that's just not quite right. And then they develop this kind of patterned response that doesn't let them burp. They just don't know what to do or how to do it. So when you give them 1,000 burps or 2,000 burps, and we tell people, we want you to be mindful, we want you to kind of pay attention to the cascade of sensations and the head positions. And because if you analyze your own burps, I never did until this disorder came along, you discover that there's a sort of a gesture that you do in, you know, just prior to the burp. And so we're helping people find that gesture. And because otherwise I can't figure out, why would 1 Botox injection fix a thing that has been going on for 30 years? I can't think of it in any other way, but I'm sure there is something we could speculate on.
We finally have a controversy. I love it. That's what makes the panels fun. When more controversies, the better, right?
I mean, I don't know if I'm going to put my 2 cents on the table here too. I think there may be some sort of learned behavior as a child as well with reflux. And the reason I say this, my own child has had an inability to burp, and he was the kid who was always car sick. He was the refluxy, baby. He still wakes up coughing in the middle of the night because of his reflux. And when he goes to vomit, it sounds like a dinosaur, like you said, Bob.
Let out the devil, we call
The
it.
devil, yeah.
Let
So
out the devil.
I mean, I wonder if there's a group of children who ultimately may be an interesting, next area of interest for all of us, because maybe if we catch them earlier in life, A, it saves the parents a whole mess of bags in the backseat of the car. And, and B, we maybe get them on a pathway sooner than 18, 19, 20. I think the way I think of it also is that they kind of learn to burp. I think they kind of figure out what feels like a burp, how to put air in. It was funny, my speech pathologist and I both independently tried to describe how to belch to a patient once, and we had completely different gestures, completely different. So
I think we're going to have the opportunity to learn. The largest children's hospital near me, the GI division, now has my cell phone. And they just call me directly and put kids on my schedule because they can't figure anything else out.
Yeah.
And now they just ask them, by the way, can you burp? And when they can't, they say, please, maybe can you take a look at them and do something? Because, before we do 4 more tests, can you figure something out? And so we're now seeing a younger population down 11 and 10 years old and direct referrals from the children's hospital. So I think we'll start learning more about the development of this disease around that time where the kids or the adults are telling us they first really noticed it.
Yeah.
I think they're only noticing it because the other kids are burping on the playground and they can't partake in the games and to play with the other kids, and they realize there's something different about themselves. Where their parents have known maybe that their diet is a little different and the way they feed is a little different and some different things. So I think there'll be a lot we'll learn in the next couple of years as we deal with the younger population and we deal with the older population and see that difference.
Could I say something there? I made a video, a YouTube, called "My Baby Can't Burp," and the reason is when you talk to 1,000+ people who can't burp, and their parent is with them because they're 18 or they're 16, or we've got 9-year-olds and 7-year-olds. When you talk to parents, a percentage of them, many of these people could burp fine as babies, but of that third who didn't burp well or had a lot of colic or spitting up, those are the things: gasiness, projectile vomiting, colic, and spitting up, and we pounded and couldn't burp them. When you talk to that third who know about their infancy through their parents, they can sometimes describe harrowing experiences. In other words, the parents were on the ledge, and one father said, "This is our third child. If she had been our first child, she would definitely have been our only child." So I thought to myself, well, we need to find these poor beleaguered parents. And so that's why I put out a video that says "My Baby Can't Burp." And I said in there are going to be pediatricians who are going to say, "What? You're going to put Botox in a 2-year-old?" But when you hear the story, it is so extreme in some people that it at least has to come to pediatricians' attention, this disorder. It has to.
I'll just ask you to be careful, Bob. As a third child, I'll tell you that's a common comment about third children, whether they can burp or not.
Yeah, I think it's
I'm a third child too.
really interesting area. We have a few minutes left. One common question theme that's coming up is any correlation with RCPD and anxiety. If you have any thoughts on, is one caused by the other, or do they just go hand in hand because of the disorder?
So we're actually we're doing a prospective trial for all of our patients. They all do a baseline questionnaire before they get any treatment. And in there is an anxiety score. And it's definitely related to it. And then we're seeing that when they finally we have them do it again at 3 months, 6 months, and a year, that their anxiety in general has decreased significantly. And I think that's, it's nice. We're going to have prospective data about that to show it. So, is it a chicken before the egg? My guess, the majority of these patients seem like they're just anxious about their inability to burp and the symptoms that come with it, and being heard to the gurgle, the gurgles being heard, the flatulence, the having to drink a beer but can't really drink a beer and gonna have to leave the party because of that, and all the things that go along with it. And as we talked about, the injection itself is not that complicated, but the reason why I like it is because they're some of the happiest patients that I have, because of so much goes into this in terms of how it impacts their quality of life.
And I don't know if the audience knows this, but I don't think any of us spoke to each other saying, hey, you got to go look for RCPD patients. This population found us. And it's very interesting in 2023 to have almost like, at least for us, Bob, you've been treating these for years now, but to have a new syndrome almost, or a new disease process where we can help somebody in such an impactful way. So, first of all, thanks to all the people who have spread the word about this through the, Reddit chat threads and Dr. Bastian's work and publications that he started before any of us. But it's just a really fascinating sort of the opposite of how things usually work in medicine, at least recently. So how do people find doctors who treat this? How can we direct people to the right places so they don't unfortunately have to fly to Chicago to get this done anymore? Because we do have a lot of questions. Yeah, go ahead, Bob.
I'll tell you what I tell people, because I get inquiries from all over the place. And what I say to them is this: don't waste your time with in-person visits. Use the phone first. And I say, call very large ENT groups. Do not do GI. I mean, I love my GI colleagues, but they just want to do a lot of tests, and it just never, ever goes anywhere. So I say, call large ENT groups. And I said, if a group has done even one person, even the scheduler will know about it because it's novel and it's interesting. So ask the scheduler or the triage nurse, does any of your doctors help people who can't burp? If they've called a number of places and they get nothing, then I say, ask for an appointment with a laryngologist and take the description of the original 51. It's an open source article, take it with you. And because it's the laryngologist, we are the ones who deal the most with the cricopharyngeus muscle for swallowing. And so I think we're the ones, you don't want to go to the otologist or the rhinologist, you want to go to the laryngologist, the voice, swallowing, and airway person. And I say to them, you may need to travel, to New York, to Boston, to Philadelphia, to a nearby larger city. And then I always say, and if all else fails, come to Chicago. And I also, by the way, I usually tell people, now, if you get somewhere and they say, well, sure, we'll do this, but we want you to see this person and we want you to do this test and that test. I usually say to them, you might consider just saying to them, thank you, doctor, for being so thorough. I appreciate your interest in being, but do you mind if I just go straight to Botox? Because after 1,200 people who've had every test known to man and not one of them got a diagnosis, it beats people up, and so I explained to them, Botox is a test. It's a test and it's a treatment. And so just nicely say to, if you can't find someone who will take you straight to go, call the next group.
I mean, I would echo that. I think if you find otolaryngologists that specialize in swallowing, we're the people that are familiar injecting Botox. And your description, Dr. Bastian, was exactly what happened to me. A patient came to me in the beginning of 2020 and said, I have this condition. Have you heard of it? And I said, I have not heard of it. They said, Dr. Bastian wrote this article and this is what I have. And I said, well, I can inject Botox into your cricopharyngeus muscle. And from that's how I started getting many more patients. And so we did a survey on Reddit of kind of how patients are finding their doctors, and the majority are being diagnosed by otolaryngologists. So I think that's really a charge to us to increase awareness to our GI colleagues, our pediatric colleagues, and other people to look into this diagnosis more so patients don't have to see many providers, because the majority of patients I see have seen quite a few providers prior to discovering this diagnosis on the internet and then finding me.
All right, so I'd like to be respectful of everybody's time. It's now 8:30 on the East Coast, and we have used up our whole hour. For people who have friends who missed the webinar, it will be on the ABEA American Bronchoesophagological Association website for a certain, I think, period of time so people can watch the webinar recording. And I can't thank you all enough for spending an hour with us, and hopefully this gives you and your family and your colleagues some great information about RCPD. So thanks, everybody. Thanks to our panelists, Dr. Odell, Dr. Spiegel, Dr. Pittman, Dr. Bastian,
Thanks,
and
Tom.
Martha at the ABA. We really appreciate
And
it.
thanks, Tom, and thanks the ABA.
Yeah, thank you. Thank you.
Thank you.
You.
Bye, everybody.
Bye-bye.